Welcome to this series of lectures in oral medicine. This lecture is entitled Allergies and Immunological Disease. Before we start, we'll talk about the scope of the presentation. We'll run through some background facts, an overview, etiology, risks, management, and clinical implications of hypersensitivity. The immune system is essentially protective against infection, but response also can be damaging, where you have a breakdown of mechanism dealing with self-tolerance. This leads to autoimmunity. Humoral immunity involves immunoglobulin with antibody activity, be lymphocyte-derived plasma cells, others such as macrophages and polymorph nucleoleucocytes, and complement. Whereas cell-mediated immunity involves T lymphocyte-mediated system and is responsible for the development of delayed hypersensitivity. T helper helps plasma cell antibody production, and T suppressor cell suppresses this. So in this diagram we talk about the types of hypersensitive reactions that can occur: anaphylaxis type 1, cytotoxic type 2, immune complex type 3, and cell-mediated type 4. These should all basically be revision for you, but these diagrams from Kobayashi et al. Indicates how this mechanism within the different categories works. So again, if we list the type 1 involves mainly IgE, and this is where you get anaphylaxis or atopy. Type 2 is where antibodies are involved, IgM and IgG, or complement. For example, autoimmune hemolytic anemia. Type 3 is the immune complex, IgG and complement. Example, systemic lupus erythematosus. Type 4 is delayed type hypersensitivity, where you get a cell-mediated immune response, and this involves memory. So, for example, contact hypersensitivity involving T cells. And type 5 is a distinction from type 2. It's an autoimmune disease, IgG, IgM involved, and this is where pemphigus pemphigoid and perhaps other conditions may be involved. Today we're just going to be talking about 1 and 4. So if we go back to atopy, type 1 hypersensitivity, common forms are hay fever and asthma. This is the most common type. It affects about 10% of the population, and there is a strong genetic basis. IgA deficiency is often associated in these people, and it's related to IgE, the mechanism of hypersensitivity. What happens is IgE attaches to basophils and mast cells, so when the allergen is encountered again, these cells produce prostaglandins and leukotrienes, as well as release histamine and other substances, and this is where you get all the signs and symptoms associated with urticaria, swelling, edema, angioedema, and so on. And the urticaria and angioedema may occur from in dentistry, latex, so in the gloves, but in the general situation, food allergies, medication allergies to penicillin, aspirin, and so on, animal and plant products, pollen, insect stings, environmental, heat, cold or exercise, water, and others. So when we bring this back to the clinic, remember to listen to the patient who's telling you the diagnosis. So the history is so important, family history as well as history of previous reactions, the allergies to medication and other things. Features clinically may be raised, red itchy wheals, swelling of the skin and lips, and there may be 3 types of reactions that occur. Irritant contact dermatitis, which is not really an allergy to proteins and chemicals. Allergic contact dermatitis, which normally occurs about 12 to 48 hours later, which is type 4 hypersensitivity, or the immediate allergic reaction, which is can be the most serious, which is type 1 hypersensitivity. So clinical implications involve prevention, so we must take first of all a detailed history, look for signs of allergy or hypersensitivity, use of powder-free gloves because the allergens often bind to the powder and become airborne and are inhaled by not only the patient but the staff. Non-latex gloves should be available for those patients that are allergic, and allergy testing may need to be done at times. Treatment involves antihistamines and steroids or prednisolone. Antihistamines can also cause dry mouth. But remember, xerostomia is only a symptom. It's not. It's different to hyposalivation, which is the lack of saliva. So, what are the implications of dry mouth? You have an increased risk of caries, oral ulceration, and infections. So, effective, for example, with orthodontic appliance and dry mouth, you might get a worsening of the situation with caries. Salivary gland disease will be discussed at a later lecture, but this is just an introduction to that. So, where's the evidence for the evidence is that a 1994 study indicated that more than 6% of dental staff tested were positive for type 1 hypersensitivity, whereas compare that to 1% of the general population, so there's a higher risk, and 20 to 60% in patients with spinal disease, where a lot of exposure occurs to latex. In 1998 to 2000 study, a showed a tenfold increase in reported reactions of NRL during orthodontic treatment, whereas a decrease in the reaction to metallic components also occurred in a study by Jacobs and McDonald. Survey of Norwegian orthodontists showed 15 out of 410,000 or 41,000 reactions, mainly to elastics and NRL gloves. So NRL, natural rubber latex, is manufactured from the sap latex of Javier Bacillioensis, which is allergenic. Some of the chemicals then are added during the processing, and these may be allergenic. So this is how the hypersensitive aspect comes into latex, natural rubber latex. Latex products include gloves, condoms, balloons, carpet, and a lot of things that are used within dentistry. Latex related to dentistry materials and products, so rubber gloves, rubber dam, rubber sleeves on props and light blocks, prophy cups, point wheels, orthodontic elastics, gaffer perca, some items on protected glassware, some protected clothing and face masks may also contain latex. Other allergies related to dentistry also include medication, so antibiotics. This is not really related to ATP, penicillins and cephalosporins, aspirin and other non-steroidal anti-inflammatory drugs may also commonly create allergies to patients. Clinical implications, so repeated exposure of latex products increases the risk of sensitivity. Dental staff, 25% of healthcare workers with hay fever may be sensitive to that latex, according to Weedy Tal 2001. Frequent visits, especially with orthodontics, you have frequent visits, and that can impact on the possibility of getting a hypersensitive reaction. Allergy testing is difficult due to the possibility of inducing an anaphylactic shock, but what we use is the IgE RAST radio allergosolvent testing for type 1 hypersensitivity. Other possible allergies that may impact on orthodontics: nickel in fixed appliance. Nickel is the most common contact allergen for adults. Patch testing in the USA and Canada indicated 16.2% of people were found to be sensitive. Often these reactions present only as a pruritic, itchy papules, vesicles right under the jewellery, and so on. Intraorally, the reactions tend to be lichenoid plaques or erosions. These are most commonly to palladium and mercury, and most of these also seem to have a sensitivity to nickel. There are reported cases of oral eruptions from exposure to nickel in orthodontic braces. Patients have been initially sensitized through nickel jewellery such as earrings and diagnosed with nickel allergy through 5% nickel sulfate in petroleum jelly. So clinically we need to try and prevent, so avoid titanium arch wires, use stainless steel based ones, TMA or pure titanium. With regard to stainless steel brackets, which have a low nickel content, so safer. Also ceramic titanium or gold plated brackets. Magnesium and others concluded that higher concentration of allergen is required on the mucosa compared to skin to elicit a reaction. These are some of the latex-related products that are on the market. As you can see, it's quite an extensive list. So in summary, type 1 and type 4 hypersensitive reactions are a reality in orthodontics as well as dentistry. Contact dermatitis is also a problem. Reduction in risk is mandatory. Natural rubber latex allergy is a significant risk for not only for patients but also for healthcare workers. Prevention is the best form of practice. Now we turn to part 2 of this discussion on immunological diseases. This is type 4 or delayed type hypersensitivity. If we talk about recurrent aphthous dermatitis, again this condition will be covered in another lecture in the series, but what is recurrent aphthous? Recurrent aphthous dermatitis, as we know, is the minor form which is quite easily diagnosed clinically with has an ovoid shape, round shape with a necrotic centre and a erythematous halo surrounding. They generally last about 2 weeks and can involve any surface of the mucosa. Compare this to major form, which is more than 10 millimeters in diameter, and they tend to take longer to heal and often heal with scarring. And then the third variety is a herpetiform, which usually incise 1 to 3 millimeters, but can coalesce to form larger ulcers, and they generally tend to heal within 2 to 3 weeks. So it's a common mucosal pathosis. There's a wide range in incident reported in the literature, but in terms of pathogenesis, the cause appears to occur as different things in different people, so it's varied. But what we do know is peripheral blood may show increased ratio of CD4 plus to CD8 plus lymphocytes and raised TNF alpha. Epithelial destruction appears to be a local T cell mediated response involving T cells with TNF alpha and macrophages and mast cells. So what happens is the T cells tend to, in simple terms, destroy the mucosa. But what is or are the initiating or associated factors? Recurrent aphthous dermatitis initiating factors may be allergies, a genetic predisposition, 9% chance that children of both parents who have RAS may also get RAS, hematologic abnormalities, hormonal influences, immunological factors, infective agents, nutritional deficiencies, smoking incidentally seems to have a protective effort against RAS, and stress with its effect on reducing the immunity, and trauma. So nutritional deficiency and sensitivity has also been reported in the literature. In general, there's a primary immunodysregulation with cyclic neutropenia, HIV, which show elevated CD8 to CD4 ratio, decrease in mucosal barrier, so trauma, nutritional deficiencies, smoking cessation will reduce mucosal barrier and therefore make people more prone to getting these types of ulcers. Increase in antigenic exposure, so it appears to be a primary factor, things such as sodium oral sulfate in toothpaste, medications such as non-steroidal anti-inflammatory drugs, beta blockers, microbial agents such as Helicobacter pylori, viruses have been implicated in foods, and so on. So recurrent aphthous stomatitis, in summary, these factors would, these background factors would make someone more susceptible or prone to getting this type of ulcer. So if we look at this case where 17-year-old male is referred with regard to painful ulceration, we know that the majority of ulcers occur before the age of 30. Medical history, there's a query on smoking, but there is a family history of similar ulcers. No allergies, but stress at this age, there may be exam time, or that may be just starting a new job. You would need to look at the toothbrush age and wear, because if the bristles are frayed outwards, they're more likely to cause trauma. Also, we need to consider, are there any other systemic disorders that are associated, because we know that RAS is associated with Behçet syndrome, celiac, and other systemic problems. So you may carry out some blood tests for blood erythrocytes, C-reactive protein, hematinics, glucose, rule out and or correct any nutritional deficiencies to see whether you have any improvement, presence of any autoimmune disease, infection or inflammatory conditions, diabetes. If they're for a food allergy, very difficult to diagnose this, but they would have to keep a food diary for 1 month to 2 months with everything that goes in the mouth being recorded, and then linking that with the timing of an ulceration. Elimination diet is also another possibility to know common foods. So therapy, you can have over-the-counter anesthetics or bioadhesive products such as Sivacaine, which is an anesthetic mouthwash, anti-inflammatory infective agents such as Diflam, chlorhexidine mouthwash, topical steroids on occasions, topical antibiotics. Others in the literature include Melatomox, Epsone, thalidomide, but these also have other side effects. Review of possible traumatic factors such as worn toothbrush, and elimination of any obvious food sensitivities. So here, from Neville and Dan et al. Shows use of 5-day therapy with beta-methylpone therapy, the before and after, before being on the left. So in summary, RAS is a T-cell mediated mucosal destructive problem. Susceptibility, well, people are more prone to getting these type of ulcers from trauma, toothbrush orthodontic demands. Investigations may involve a good history and blood test to rule out any underlying medical problems and or deficiencies. Management involves correction of any of these predisposing factors where possible and supportive and topical measures. Thank you very much.